Hello, my name is Megan Bretz, and I am a physical therapist at Ascension St. Vincent, which is located in Evansville, Indiana. Today I've been asked to share our story around the implementation of high intensity gait training at our facility, which is a large community based hospital system in somewhat rural southwestern Indiana. It's a story of a practice change that began in our small 25-bed inpatient rehab facility in 2012. So, over the course of the next 25 minutes or so, I'm going to summarize the steps that we took to change our very outdated practice, including the trials and tribulations of this effort in light of the emerging evidence. In the fall of 2012, our treatment strategies to improve walking in the neurologic population fell into two major camps. We had clinicians, such as myself, with treatment approaches that prioritized the restoration of normal movement patterns through very specific handling techniques. Patients were systematically progressed from simple to complex tasks as their movement quality and skill improved. This is what I had learned in PT school, and these key concepts were the entire focus of a certification course that I had completed in 2005. We had other clinicians that focused on treating the impairments themselves with interventions like therapeutic exercise and isolated balance activities. Looking back, I really don't know how much actual walking practice our patients were engaging in during these sessions. It couldn't have been much because clearly we were focused on these other things. We also had no idea how hard our patients were working. We weren't taking vitals routinely, let alone monitoring heart rate response during sessions. Based on how patients looked and the fact that they could easily engage in conversation during sessions, I'm guessing it was low. The only standardized outcome measure that we did consistently was the FIM, the one that we had to do. So around that time, I was asked by St. Vincent to present at an in-house conference on physical therapy interventions in stroke rehabilitation. The presentation I put together was based on what I knew at the time to be best practice, which was heavily focused on movement quality and other NDT principles. I sent my presentation to a respected colleague in the field, requesting her feedback, and her response was in the form of two papers: the 2008 Climbs and Joan publication, which has been mentioned in previous talks, and an editorial by Catherine Sullivan, who is the president of the neurology section at that time. I'm going to read a quote directly from her paper. "The time has come to let go of the neurophysiologic approaches as a basis for neurologic physical therapy education and practice. Instead, we should discuss the therapeutic principles that drive the nervous system to respond and to adapt." These papers and the conversations that followed were a turning point for me. I was fairly certain, although I didn't know for sure because I wasn't measuring, that I wasn't doing enough of any one specific functional task, in this scenario, walking, at a high enough intensity to make a significant difference. Clearly, I had some catching up to do. In the spring of 2013, Dr. Hornby invited me to his locomotor recovery lab in Chicago, where I was able to observe how clinicians there were trying to focus on high-intensity, task-specific walking practice in a variety of environments in both the research lab and in clinical practice on the floors. The next day, I attended the Walk the Walk course, where I learned how these principles of neuroplasticity might be applied to walking interventions following neurologic injury. Honestly, even though this approach was so different than what I had been doing, it made sense. In order to improve in a skill, you have to practice it a lot and at high intensities, and making mistakes is a critical part of learning. So, in March of 2013, somewhat overwhelmed, but also armed with all of this new knowledge, I made some big changes to my practice. Number one, I started prioritizing walking, meaning I severely cut back on the practice of non-walking tasks for those patients that had the goals to improve in walking. Number two, I established baseline vitals, identified a training heart rate range, and started targeting these ranges during our sessions. Number three, I stopped focusing on the quality of movement because emerging evidence was indicating that emphasizing the recovery of, quote, normal movement patterns maybe wasn't as important of a factor to walking recovery as I had once believed. And number four, I started incorporating standardized outcome measures so that I could understand how my patients were responding to my interventions. So I get it back from this course and I have all of this new knowledge and I'm trying to figure out where to even start with this. So I started by sharing with what I had learned. Our team was made up of clinicians that had been practicing for a very long time. Like me, they had very established practice patterns that they were comfortable with, concepts that they had been taught in physical therapy school, and concepts that had been reinforced along the way with a variety of continuing education courses. So I started teaching, starting with the basic principles of neuroplasticity, specifically the principles of task specificity, repetition, and intensity, and how these active ingredients are defined and could be manipulated and translated to the patient sitting in front of you during a session. I also shared a different way of evaluating and treating gait that had been introduced at the Chicago course. Instead of looking at our patients kinematically, I suggested looking at them from a biomechanical perspective, utilizing a framework that allowed clinicians to identify and target certain parts of walking that were problematic for their patients. Additionally, I shared the evidence regarding the safety, the feasibility, and the potential outcomes of trying this new approach. Next, I created some things, guides for when and how to target the specific subcomponents of gait. This is actually a snapshot of one of our earliest logs where clinicians could record session details that included components like speed, intensity, distance, and how we were assisting or resisting the different subcomponents of walking with our patients. We also started monitoring heart rate and blood pressure with equipment that we already had on the unit, and eventually we had to purchase more of it. Finally, I printed off RPE scales and posted them around the gym for patients to report exertion during our sessions. And I just started doing it, problem solving through the barriers and modeling this behavior myself. Despite the fact that I'd shared this newfound knowledge with my colleagues, they were skeptical. There was definitely concerns about not addressing the impairments or not working on things like transfers. And there were concerns about patient safety from both a fall risk standpoint and a cardiovascular standpoint. The pushback was real, and this practice change that I was trying to get pushed through was slow going, which honestly I found very frustrated. I needed a partner, someone to get on board with me. So, a couple of months into my own practice change, St. Vincent hired a new graduate and I was assigned to be her mentor. She was eager to learn and got on board quickly with high intensity gait training, despite the fact that this approach was not at all what she had learned in PT school either. Teaming up helped a lot with caseload sharing, and we could brainstorm strategies on how to get this done together. We quickly realized we needed some more equipment to help us deliver this safely and efficiently, which would hopefully help with more clinician buy-in overall. So over that first year, we were able to purchase a few more things. Fortunately for us, we already had a portable bodyweight support lift system and a treadmill, which was a great place to start. Both were literally sitting in the lobby of our inpatient rehab facility. That's how infrequently they were used. We unburied it and started using it. So one of the biggest issues we had initially was with the walking harnesses. Anyone that needed any amount of bodyweight support hated them because they were so uncomfortable when patients were being lifted. I happened across these very inexpensive walking shorts that could be used with most lift systems. Unfortunately, not ours. But we were able to rig up an adapter piece for our lift system to make it compatible, and it worked. Patients thought the shorts were more comfortable, clinicians were able to get them on more quickly and easier, the problem was solved. Another problem with high-intensity gait training over ground was that it wasn't being done. It was pretty much just being delivered on the treadmill. We had to find a way to get more overground practice in, which meant that we had to find a way to keep people safe while they were trying it. So I wrote a letter lobbying for some sort of overhead track and harness system, a smaller version of what I had seen they had installed in Chicago. Nothing fancy. We just needed to be able to keep people upright. And we got it. Because of the security these basic systems offered, patients and clinicians were much more comfortable and willing to attempt more challenging overground walking activities. And clearly it worked. I want to share the first of two cases in this presentation so that you can get an idea of what our early efforts at doing this looked like. This particular patient was 35 years old and she was admitted to acute care with an infection that had impacted her spinal cord. She presented initially as a C4 AIS-B. The first 2 weeks of her stay were focused on stretching, positioning, and patient education. There actually was no family to educate, and we were fairly certain she was going to discharge in a wheelchair to a skilled facility. But at 2 weeks, we saw the first flickering of movements in her legs. So a year ago, our interventions would have been the standard progression of tasks, and heart rate would not have been measured during any of this. But that's not what we did. We calculated a training heart rate range, and we got her on the treadmill and body weight support. So this is one of our very first attempts at treadmill training with this patient. It took us 30 minutes to get her from her first floor room up to the second floor gym, into the harness, up on the treadmill, and secured in the lift. Lots of padding, lots of strapping, lots of hands. Again, other clinicians watching this production are probably wondering what in the heck we're doing with her. Heart rates were low, exertion was low, total stepping time was low. But she could barely move at this point. We are all just trying to figure it out. But the more we did, the more efficient we got, and the less hands we needed to get there. Watching this now actually is a little bit painful for me. The treadmill is going so slow, but at this time, what we were doing here was monumental. So fast forward 3 weeks, she's getting better. She's still super slow, but she's barely getting any body weight support, and she's managing her legs independently. In the second video, we've got her on the stairs, even though she's not walking well on the ground, because stairs are challenging. They clearly provide a lot more variability, and she needs to be able to do stairs when she gets home. And we're just letting her figure it out, which means that she was making mistakes in her movement, and we're adding challenges as she becomes more successful with the activities. Another 4 weeks go by, she's even better. She's a little faster, we've added some cuff weights to her ankles, she's not getting any body weight support. In the second video, she is on a flight of stairs with just me, managing her legs herself, and I'm providing minimal assistance to steady her. This patient discharged home after 7 weeks of inpatient rehab on a rolling walker. She was a huge success for us at that time, and all I can think looking back at these videos is how hard we thought we were pushing her at that time. The next several years were a whirlwind of implementation efforts, and I was working hard on a lot of fronts, targeting a lot of different audiences using a variety of strategies to push this practice change through. So in talking to the physical therapy students from the local university during their clinical placements with us, it became clear that this content was missing from their curriculum. There was an opportunity there for me, and I was lucky enough to get hired on as an adjunct faculty member. I started integrating current evidence on high-intensity gait training, so when the students came to our facility for clinicals or as new graduates, they were far more prepared for what we were doing. I started working with groups like the Institute for Knowledge Translation, who are producing, translating, and successfully applying this evidence in the clinical setting. I was fortunate to be part of the Knowledge Translation Task Force for the Locomotor Training Clinical Practice Guideline that was published in January of 2020, where I could brainstorm processes and strategies with others in our shared endeavor to implement this practice change. I also explored a lot of different ways to get this information out, sitting down one-on-one with students and colleagues to go over cases, and sharing the evidence on our outcomes in several different platforms. After earning my NCS in 2016, I started advocating for the development of a clinical practice leader position. This position was created the following year, which allowed me more time and leverage to implement these and other practice changes based on current evidence. We also developed a neurologic residency program with a very clear mission to develop change agents who would help close the gap between evidence and practice. Our resident is very involved with this particular implementation effort. Around this time, I started pushing implementation of high-intensity training into our outpatient sites. The management of this patient population in outpatient was very different from what we were doing in inpatient rehab with high-intensity gait training, which was confusing and frustrating for the patients. Many told us their progress had stalled or they'd simply stopped going to outpatient physical therapy because they didn't find it valuable. So I started treating some patients in outpatient. My approach to patient care, which was basically pushing patients very hard to the point of failure, was completely foreign to them. I covered the gym and obstacle courses as pictured, using really anything I could find. I rigged up a sled with a rope and a bunch of cuff weights and made patients drag it all around the gym. I used what I had available. Seeing patients struggle and fail was initially very unnerving for these clinicians. But as they saw patients improving, the skepticism transitioned to questions on what I was doing and how I was doing it. I started mentoring there, and more clinicians started moving away from the impairment-based interventions to begin prioritizing walking. So here's the funny thing. When you start implementing a practice change and you show the positive results of your implementation, people that make big decisions start listening, especially if it impacts the organization in a meaningful way, like reducing length of stay or discharging home at a higher level of function. So let me give a couple of examples. Last summer, we were able to add a second bodyweight support treadmill system in inpatient rehab. Our single system was constantly double booked. It was a long-standing issue. But this was a need actually noticed by our new medical director after we shared our functional outcomes with her. She actually lobbied for a second system. Last fall, we opened up a new outpatient site that is completely outfitted to meet the needs of our neurologic population working on walking recovery. Given our previous outcomes, I was consulted in the space design, so the whole gym is supported with an overhead harness system, and we have 4 treadmills, 2 with lift systems integrated, and 1 with a virtual reality component. As the evidence started pushing more towards the active ingredient of intensity, being able to continuously monitoring heart rate became very important. So we invested in several chest-based monitors that read to our departmental tablets or clinician phones. This was so much better than the periodic checking that we were doing with the pulse oximeter. And now we could see how the patient was responding to the intervention in real time. More resources were developed to help clinicians calculate a patient's training heart rate range and then program this information into the heart rate monitoring app for use during a session. Last year, we were able to purchase an iPod and a heart rate monitor for every clinician inpatient and at our new outpatient site, and that heart rate monitoring set is carried from patient to patient throughout the course of the day. In response to the core outcome measures clinical practice guideline that was published in 2018, the outcome measures that had been suggested for administration several years prior were now implemented in a formal battery. In early 2019, I started training clinicians on the new protocol, including the interpretation of testing results. I encourage clinicians to discuss testing results with patients and include patients in decision-making for treatment, which is the perfect time to start educating and getting patient buy-in for high-intensity gait interventions. And here we are to our second case, present day. Another spinal cord injury, but this time the result of a motor vehicle accident that resulted in a spinal cord contusion and multiple rib fractures. This patient was categorized as a C4 AIS-D and admitted to our inpatient rehab facility on day 7. Interestingly, he was actually denied placement at his preferred inpatient rehab facility, a newer, bigger, and fancier facility, because it was determined during the pre-admission screening that this patient was too low level. Because of pain and significant spasms on evaluation, he required assistive 2 for slide board transfers, and he was unable to sit unsupported, let alone take steps. Given his age and sensory motor function, it was determined that he had good potential for walking recovery, so the 10-meter and the 6-minute walk tests were both scored. That first week was rough. We were not getting a ton of anything accomplished, and he developed pneumonia to top it all off. But on day 8, with a 103-degree fever, he turned the corner and we had him walking. His training heart rate range was calculated using an Excel spreadsheet developed by the Institute for Knowledge Translation, with 129 to 146 identified as 75 to 85% of his age-based heart rate max. This session was overground in the Arjo walker. I'm going to get this video started. With the PT straddling the device from behind and using a gait belt to keep his legs from scissoring so he can continue stepping. Since he's able to advance his legs, the legs are weighted for an additional challenge. The tech is actually pulling the device to assist with propulsion. The graph indicates session data on heart rate response with total time spent in the targeted 75 to 85% heart rate max indicated by the yellow bar at about 3.5 minutes. Much more time, almost 18 minutes, is spent in the moderate intensity heart rate ranges. Peak heart rate was 135, which is about 79% of his heart rate max, and RPE was reported at 18. This is pretty typical performance for the first time walking, and inpatient rehab got to start somewhere. So 2 weeks later, this is what the overground session looks like. This man is out of body weight support clearly, and he's pushing a weighted walker with weighted limbs, pulling one PT and being encouraged by another to go faster. In the second video, which is the same session, he's actually walking backwards up a ramp with weighted limbs without his device. Once he gets to the top of the ramp, he descends a flight of stairs and repeats this entire course. 28 days and 46 sessions later, this gentleman discharged home on a rolling walker with minimal assistance. From day 8 to the very end, every single session prioritized high-intensity walking, whether that was on the treadmill, overground, or both. He hit the targeted high-intensity heart rate ranges every session. Interestingly, the areas that were not prioritized, which were transfers and balance, improved. They came along for the ride with the high-intensity gait interventions. So how was the management of this case different than the first one? Intensity, we push harder, faster speeds, higher grades, heavier loads. We actually spend a lot of time now in the stairwells. So this gentleman is almost 80 years old. He had a stroke 2 weeks prior to this video, which was taken in inpatient rehab. He's skipping steps with 5 pounds on each ankle up 4 flights. His outcomes were fantastic over a 15-day length of stay. His sessions prioritized high-intensity gait training. We are also more efficient. We don't need as many hands or as much time to execute a session because we're simply better at doing it. We're also more confident and skilled in delivering this as a team. It's not just the two of us anymore. This has become our standard of care. We also sell this approach better to the patients as well, and that buy-in from them is critical. We educate patients on the evaluation when we're reviewing the results of functional testing that we've got, 3 weeks in inpatient rehab or say 20 visits in outpatient to get them from point A to point B. The best intervention that we have to make that happen is a lot of walking practice at high intensities, and it will be hard. Mistakes will be made. We tell the patients that we have the equipment to help us do that, and we will keep them safe. The alternative is a less intensive route, but the outcomes might not be as significant. And then we ask patients if they want to do that. 99% of patients say yes. We are pushing patients equally hard in the outpatient setting. This patient is 56 years old and she's 35 years post-spinal cord injury. On the treadmill, she is climbing a 15% grade with 8 pounds on each ankle and a 20-pound weighted vest. This actually is her break. The next activity is flattening out the grade but doubling the speed. The second part of her session was over ground, and I'm going to show that video now. The goal is to navigate these steps as quickly as she can with her weighted vest, pushing very, very hard. To wrap up, changing practice is hard. The first step is recognizing the gap in practice, the mismatch between what the evidence says we should be doing and what we're actually doing. After recognizing the gap, you have to be willing to do something about it. One person can start the ball rolling and keep it rolling. I did. Realize that practice change takes time, effort, and continuous problem solving. This does not happen overnight. There will be pushback. 7 years going, and we're still working to fully implement. Finally, leadership support is huge. The progress we have made, the extra time and sometimes hands that we were allotted during these sessions, the equipment that we purchased, the presentations I gave that were supported and attended by them would not have been possible without leadership support and buy-in. And their support was granted by sharing the evidence, applying the evidence, and then following up with them on a report of the outcomes. It will get you places. This concludes my presentation. Thank you for your time and interest.